One thing I noticed that wasn't discussed, it was touched on but not discussed as much, was the role of bystanders in response to overdoses. So one of the reasons the overdose rate, I would guess, in LA County hasn't gone up is because you have community-based organizations giving out naloxone to drug users. So how do you guys see that fitting in the response to this epidemic?
Oh, this is for me? I was thinking this was for Larissa or Dr. Mooney. Well,
or the LA County.
Okay, well, I'll say from a policy standpoint, it hasn't been addressed yet because they're focusing mostly on people who have an official capacity, as in the school nurses, as in the EMTs, trying to protect those people I don't know that there's been much focus on, if you're just a random person who happens to have a naloxone kit on you. Am I saying that correctly? Yeah. Naloxone kit that you would be protected. But I think it's an area that maybe should be addressed. It's something that policymakers, I think, need some education on. This is something that it would maybe be an area for future work, but I couldn't find anything on it currently.
Yeah, to your point, I mean, I think, and we just recently, and I think before when I started to talk, I work for the Department of Public Health, and I oversee all the drug treatment centers for Medi-Cal, and we're in the process of implementing the drug Medi-Cal waiver, if people have heard of that, which will provide a full array of services to treat substance use like a chronic disease, which is one of my things. But part of what we've been doing too, we just received a grant for naloxone to be able to distribute it to first responders and others out in the community. So I think that has had an impact, and we know, and I don't have the data in front of me, we have, it was a significant number of individuals that were saved last year as a result of having access to naloxone. So I think to your point, that may be part of why we see the plateau perhaps in LA County as well.
And there's also, there just could be other factors. We are seeing in the past few years, finally, a downturn in the number of prescription opioids that are being written for pain conditions. So what's actually happening in LA County specifically and the influence of these different factors, I'd be interested in more.
With the microphone, I believe.
Opioid withdrawal symptoms if they are withdrawn from it, and is it possible to do experimental detaining the people who endanger their life for 1 week, and what's the time needed to get them out of opioid addiction?
I just want to make sure I understand the question. It seemed like a multi-part question. The time frame for opiate withdrawal, and then separately for opiate addiction. What happens during opiate withdrawal? Was that the question?
Well, I think he was asking if you could. There's some legislation actually out there, I think in Ohio, around detaining people if they have an overdose. Right? Is that what you were referring to?
To get them out of it. And they have withdrawal symptoms like alcohol withdrawal?
Yeah.
Oh, yeah.
Okay.
Yes, yeah. Opioid withdrawal is very, very uncomfortable. So, alcohol withdrawal is known to be potentially fatal. But if we are anticipating somebody going into withdrawal, we usually give them medications in an inpatient setting, because to just go through the withdrawal alone, the relapse is inevitable. So people just don't make it through just self-detoxing. Typically, they'll relapse. So having medication support to make the withdrawal process more comfortable, and then facilitating treatment at that point is the typical standard of care.
Okay.
Can I just say something real quick? I think that's the biggest reason why people switch to heroin is because the withdrawal is so severe. My understanding is, and correct me if I'm wrong, I had a specialist tell me once that literally your brain is sending signals to you saying, you will die if you don't do this. And so people, they don't have access to opioids maybe anymore, and so then they go to heroin because heroin reduces that and fulfills the same, chemical urgency.
Right. I mean, they're all opioids, and they act in a similar manner in the brain. And so if you have run out of money because prescription opioid habit is more expensive than heroin, that would be one reason that people switch. But yeah, once you're addicted, there is this compulsion and loss of control that you'll use whatever opioid is available.
Yes, sir.
Could you please describe evidence-based therapy that is effective for curing opioid addiction or mitigating it?
Yes, I hesitate to use the word cure. I wish it were that easy. We view it as a chronic disease that requires ongoing treatment like other chronic illnesses such as diabetes, hypertension. The best evidence that we have for the treatment of opioid use disorder is medication treatment. So what that means is that the FDA-approved medications that are available to treat opioid addiction have the best evidence supporting reduction in relapse and longer-term success and retaining people in treatment. So the medications that I mentioned earlier are considered the gold standard. If somebody is just detoxed from opioids alone and then sent back out, relapse is almost 100%. Yes.
Well, I would just add to that that's an important part of it, but I think counseling is another important part to understand what the traumas are. Because again, no one is born an addict. There is a reason why they use drugs. I think in many situations, many people experience trauma. There's issues that they have led them to using drugs. I mean, there could be because of prescriptions. It can be to get over some point in their life that was very difficult, and they started using drugs, and then they become addicted to it from a psycho or from a physical, in terms of a physical response within the brain. But I think you have to pair it with counseling. It's not just a matter of providing a drug to, because I think drugs Vivitrol, for instance, I think is very critical in reducing your desire for your next fix. And it works for 30 days. And I think the thing clearly, if the importance of that, I think to me is, while you're have that without it, it's very difficult to treat people, because if you're sitting there getting counseling, thinking about where am I getting my next fix, you're probably not doing very good on the counseling side of things. So, but I think the two have to be paired.
Just a follow-up question. Is the necessary implication of your comments that because the nature of the disease is chronic, that the patients will indefinitely have to be on the medication? And a related question is, if the answer to that is yes, that they will indefinitely have to be on the medication, are the insurers, the health plans, the medical insurers, Medicaid, paying for such long-term treatment with the prescription drugs that are necessary to treat the chronic disease? So two-part question.
Yeah.
Do they have to stay on the medication because it's a chronic disease? And second question is whether the coverage is there from the sources of payment to pay for the long-term use of the medication.
Right. The treatment over time really varies, and we try to individualize it. So are there some people who eventually can come off of medication and be successful as they engage in other kinds of behavioral treatment or psychosocial support? There are those individuals. So I think the decision about how long to continue medication is something that we have to make case by case. There are some people that relapse again and again and again, and they seem to do better with long-term medication treatment. And we do know that staying on the medicine longer tends to predict better chances of success. And you wanted to answer part two. My
I'll take part
experience
two.
has been that insurance will cover the medication if it's indicated. So it involves, a justification, and Sometimes we have to get authorizations and
So on the macro level, I mean, I think you're definitely correct on the individual level for people who are insured. On the macro level, the question is whether or not any kind of substance abuse treatment or any kind of mental health is included within the insurance coverage that people have. So the Affordable Care Act went a long way to addressing that on the individual market, making it essential health benefits. Those things are under attack right now. So not sure whether or not that's going to continue, although I think it looks actually pretty good that it will by inertia. So hopefully. But in the Medicaid side, they definitely have the coverage depending on which state you live in. California is a fairly generous state in terms of Medicaid benefits and what is covered. Other states are not necessarily as generous. So with Medicaid, it really depends on where you are. On the job-based coverage side, which is what half the country has, and most of the people consider that to be, the main system of the country, it is incredibly varied because you get basically whatever your employer deigns to pay for. But if you're unionized, you will get better benefits. Yay, Cal State and UC unions. I get great benefits and have for a long time, but not every worker has that. If you're on something called an EPO, which is a new fangled way of saying very, very bad coverage, the particular medications that your doctor is prescribing may or may not be covered, and there may or may not be limitations in terms of will they prescribe it for months on end. And certainly there's no question that if you're in a long-term treatment, you do have to get periodically reviewed and the prescription has to be periodically reviewed. But people do bump up against limits of, well, my insurance is only paying for 3 months of this, 2 months of this, and my doctor's telling me I need it longer, and now I have to pay for it out of pocket and start using things like a new app that they advertise on TV that tells you where the lowest prescription drug prices are to go if you're uninsured. Buy it from Costco.
Okay, let's we'll come back to you. Let's someone else have a chance.
I'm Dottie Wiley from the School of Nursing. So one of the questions I have, Wes and others that are involved in public policy, is that in order to move Narcan distribution over to sort of normalize it within the population and spread it beyond school nurses, we really have to move it out of where I currently see it. So I teach public health and I teach down in Skid Row often. And so the homeless health care has been distributing Narcan and training people, 700 to date that I know of. Wow. And have treated about 1,000 people in the area, but that's in Skid Row. And if you talk to people, hardly anybody who's not there knows about it. And it seems like a public-private partnership we could move towards. But also, I think we have to take it out of the stigmatization that this is a problem with people that live in Skid Row.
Yeah.
It really needs to move out into other areas. I think the best example of that is Baltimore.
Yeah, why don't I take that because I sort of do that stuff. So yeah, there's 2 organizations that give out naloxone down in Skid Row. So Homeless Healthcare and the Los Angeles Community Health Project. In fact, we're going to be presenting a paper on some of the impacts of their work at a Montreal conference in 2 weeks. And what we've seen in my studies is that the number of overdoses have doubled downtown between 2011, 13, and 2016 among people who inject drugs. And in LA, where we did not have great naloxone distribution in the earlier period, only 4% of witnessed overdoses were responded to with naloxone. And in 2016, it was 40%. So those programs have been hugely important and I think highly successful, at least from the data I have, at addressing that issue. The one, it's worth noting though, and I think your point is spot on, that who overdoses? Right? So it's a complex social, biological event, often having to do with naivete in terms of your own drug use patterns or not knowing what's in the drug, and then stigma. So if you use alone or you're trying to hide it. So Vancouver, which is on the West Coast and has a huge problem because of synthetic opioids, so fentanyl, many deaths. There was 126 people who died in Vancouver in March from overdoses. And most of those people weren't the folks in the downtown east side who are chronic, long-term heroin users. It was the kids on the outskirts. So younger people who partied on the weekends, coming in. And in fact, actually, there's some evidence that all of the drugs are getting cut with fentanyl. So people are overdosing from smoking cocaine or smoking crack. That's been cut with fentanyl and using other drugs. So, I mean, I think the thing I worry about is if those synthetic products make their way south, then we're going to have, a pretty bad situation in terms of deaths because they're so much more, they're so much stronger than what people are accustomed to using. And so you're right. So, and we need to get it to families and.
I just wonder how many people are misclassified, and I mean, especially in middle-class America. I can tell you that in the last 10 years, I've known 3 people whose family members or within my own family who have died from overdoses. Mm-hmm. But they don't get classified as overdoses the same way as if you're living in Skid Row.
Yeah, no, I mean, I think it's difficult. I've had some long conversations with the emergency medical service for the city of Los Angeles. And really, it just depends on who's there when it happens. And so if you just died in your room and there's no drug paraphernalia around, then you had a heart attack, or right? Or you're not with us anymore. We don't know what happened. And the testing stuff is a budget issue. And so if there's no reason to ask, then no one does. So that's certainly, misclassification is a big issue, I think. Did you guys want to respond to that?
I briefly mentioned it. I mean, I think, and Dottie, I think part of, to what you may be speaking to is among the elderly who are prescribed a lot of pain medications because of pain that they are experiencing and get their medications mixed up or whatever, and they overdose, but it's an accidental overdose through no fault of their own. They forgot they took their pill an hour ago and they take another one. And so how do we get, and that's what I was saying, I think for the elderly who are on pain medications that they could potentially overdose, they should have naloxone in their medicine cabinet, or it should be available within the household.
One of the things that came up when I was doing that analysis of AB 623, it was mentioned by Dr. Mooney earlier, is giving the amount of medication at a time. So part of that bill also, and we didn't actually include it in the analysis because it wasn't considered to be part of our mandate, but part of that bill tried to say that insurance companies cannot refuse to cover something if you do a shorter prescription period. The reason why they were doing the 30 days is because that's the normal prescription window, but that doctors need to have the flexibility to only give 3 days and still have it be covered. And to me, that also speaks to, I think, one of the things that's so important is that, and maybe is growing as a concern, is that there's been a lack of maybe, I don't know if respect is the right word, but kind of fear of opioids where people think of them as harmless. And it doesn't matter necessarily in the same way they kind of think of Tylenol as kind of harmless or ibuprofen as kind of harmless. And I mean, I see these commercials right now. There's a commercial on TV that's for a construction worker who suffers from chronic opioid constipation, and he and his doctor are laughing about it. And every time I see that, I want to throw something at the TV. Because, I mean, just the idea that it's like, oh, I can just be on it forever, and now I'm going to take another medication on top of it, and it's fine, and ha, ha, ha. It just aggravates me to no end. And I think that we need to, if we are able to get a culture where we address overdoses by training people with these kits, that maybe we'll also get to a place where we fear and respect and maybe don't use opioids until it's really indicated and necessary.
Good evening. My name is Leo Beletsky. I work at Northeastern University and at UCSD. I wanted to come back to something that Mr. Ford mentioned, which I was heartened to hear, which is the trauma issue, because I think oftentimes we don't use the social determinants lens when we look at the overdose issue, and I think that's a huge portion of this, because I think that, addiction, well, first of all, addiction and overdose are not synonymous, because a lot of people die of overdose who are not addicted necessarily, but drug use, drug misuse, overdose, all of those things are really, social determinants, trauma, all these other kind of major social and economic factors are major elements of this, and that's not something that's addressed at all when we talk about overdose. And when Dr. Mooney mentioned pain is the fifth vital sign, which is now seen as one of the drivers of, the increase in overdose prescription, that was based on data that there's a lot of undertreated or untreated pain in the United States. And that problem did not go away. We started prescribing more opioids, then we stopped prescribing a lot of opioids, but the amount of undertreated or untreated pain, broadly defined, whether it's emotional, physical pain, did not go away. So I just wanted to hear your responses to that.
I mean, I think you bring up a very important point, and really thinking about and addressing some of the issues that underlie the development of addiction, and why are people using substances, even at the recreational stage? What kinds of negative affect are we trying to numb with these pills? So it's a very complex issue, and I think the issue of therapy and behavioral treatment came up. But the goal of those treatments is to start to address some of that and allow real healing to take place. So as a physician, I think about my number one goal would be saving a life, preventing overdose death, meaning nobody can engage in treatment if they've overdosed and died. So really first reducing the harm and then building a plan. So the best plan is a comprehensive one. And not everybody is at the same stage and willing to do all of the components that we might recommend. So what can we give them initially to just start to get them engaged in treatment? But I understand and hear and your point, and it's a very important one. So trauma and abuse history, those are major risk factors for later development of addiction.
So right here.
Talk about the importance of a nice slide. My experience is we don't have a team approach. I've been a social worker in medical settings for 30 years. Nobody's ever really listened to me. I recently had a work-related injury. I work in a mental health center, and one of my clients drove his electric wheelchair over my foot. What was most effective was acupuncture. Do you know how difficult it was to get an acupuncturist?
Oh, yes.
But do I have a bag from Kaiser of patches and pills? I could probably finance my next vacation with the drug deal. And I kept saying, you gave me 3 of those. Well, there's 2 more if you want them. I hadn't opened the first 2, but since they were free, I just took them.
Yeah.
So, I mean, I think one of the things that we're talking about, and I hate to say it, is when you say, you want the pain pill? And now you go to the dentist because I had a tooth pulled while this happened. I got more pain pills.
More pain pills.
Okay, but the looking at, and I think your point is good, we don't deal with the psychosocial at all.
Right.
You want to start dealing with the psychosocial? Pay the social workers what you pay your interns, because they made a whole lot more than I did, and I was licensed, number 1. Number 2, looking at things like acupuncture, which are really effective, but to make that integrated. And I got it because I really advocated it, but most of my clients couldn't do that, and I did it because I had 30 years in a hospital setting saying, you have to give me that. So I think when we talk about that, yes, it's easy, but the easiest way to deal with it is throw the pill at somebody and give you the patch and say, I'll see you in 2 weeks.
Yeah.
There was a question here. Oh, sorry. Next. Oh.
Hi, Lori Brazel. I'm a huge fan of these monthly meetings. So I'm a writer about connected health. I would like you to speak to 2 different things, if you would, please. The first is that there have been a lot of public health campaigns. We all know what our brain looks like on drugs because we've all seen the egg in the frying pan. But there hasn't been, to my knowledge, any public information out there to help people know what it is that they're looking at when they are seeing somebody who is overdosing. And it can be many different things. So that's just one thing I'd like you to talk about. The other is, I believe, Mr. Ford, you made the comment that people, older people, will overdose through no fault of their own because they can't remember that they've taken something an hour before. But the insurance companies are now requiring that the pharmacies change the drugs that they have so that you don't have to be an old person to have all of your generically required drugs all white all the same shape, all the same size, so that you have no idea what you're taking, and it can take hours just to do your weekly medications, Monday through Sunday. And that is not through our fault.
I can comment on, I'll start up with part one, about more public awareness about what you see during an overdose. I will say at the point of distribution of the naloxone, so whether, actually now there are movements to allow pharmacists to dispense naloxone even without somebody walking in with the doctor's prescription. But at the point of the prescription or the dispensing of the naloxone from the community center, there is a training moment. And in the kit itself, there is information about what you see. So now, but the ideal scenario is that the individual who's at risk and their family member is sitting there. That doesn't always happen. So then the person you're giving it to needs to then teach their friends and family members what they would expect to see. There are some websites that do have this information very well described. Does everybody know to look on these websites? No. Could we be doing more? Of course, to really spread the word beyond the person, the person who's actually getting the naloxone.
Well, I was thinking more in terms of, walking into someone's room if you don't know that they are on drugs and you just think they're sleeping.
You think they're sleeping.
Right.
That's absolutely, that's how overdoses
if
happen.
you think they're sleeping and you go back in a half an hour, what do you know to check for?
Right.
That's what I'm,
Yeah.
Right. I mean, just to add to that, I think there isn't a lot of education around that speaks to what you're talking about. But I would point out, and I think you may have mentioned this, but I think, during the election, the one thing the Democrats and the Republicans agreed upon is that there need to be more drug treatment for prescription opioid use and opioids. I think it's interesting that because, again, the opiate epidemic for prescription drugs really is the middle class, upper class, and finally we're paying attention to it. Again, and I would go back to part of what weave this in as well. One of the things I think is the whole treatment of substance use has lived outside the healthcare system until recently. And when I give talks, I always talk about it's a three-legged stool, because often people who have substance use issues also have mental health issues, or they may have physical issues, particularly if they've been long-time users, and that we need to integrate care so that we're treating the whole person as well, because to treat one component without treating the other component, you don't. But there hasn't been the funding for substance use, because again, I'll go back to the little video that I showed in the beginning. It was seen as a moral failure. It grew out of 12-step programs. And 12-step programs, they work for some people. I don't want to negate them, but it shows that they're effective for about 12% of the population. But they're also built on, if it doesn't work, it's because you didn't do something right. It's blaming the victim. And that may work for some people if they feel they're being blamed for something, but it doesn't work for everyone. So there is a real need to start to integrate this into the medical system. And again, as someone who oversees the treatment programs for LA County for the safety net population, is up until 3 years ago, it was basically the social model. And when we started talking about more of the medical model, it was very scary to the people who provided drug treatment services. It's like, well, no, it has to be the social model. No, there's a place for both. And that's why I was trying to say earlier, the therapy and the treatment using other drugs come together jointly. But also, we need to integrate substance use into the broader healthcare delivery system. I think mental health is getting there. Substance use is probably where mental health was 15, 20 years ago. And so we need to make sure that people begin to see, and I think we'd see more education, we'd see doctors screening better at our clinics and primary care clinics. Because again, I think it was you that mentioned it, is the expert training. If you see someone who's reporting to their doctor, I come home and I have 5 drinks every night after work, that's the time to catch them as upstream, not after they've become addicted, they've lost their jobs, they're on the street. It's a long way to bring somebody back when they're there. And so we also need to look upstream and think of substance use as a continuum too. It's a disease with a continuum. It's just like diabetes doesn't show up overnight. And neither does substance use. And we need to start to think about making sure we catch and diagnose diagnose the disease early, And we need to rely on our primary care physicians for that. And it's not something primary care physicians have typically done. I mean, I will leave it to the physicians to say that, but I don't think it's something that they've typically done. And we need to figure out how we work that more into their scope of practice.
I mean, let me just add one quick thing to that, because Dr. Boletsky brought this up, and I think it's worth highlighting here, which is, there's the primary response to all drugs of addiction has been criminal. And so one of the things that accomplishes is moving people out of services, right? So they're not getting treatment in jail or prison. When they get out, they're not getting jobs, so they don't have insurance, right? And even if there was capacity in the system, and there isn't, the capacity certainly for indigent people who are indigent who need treatment is much harder than even for people who have. It's much harder than for people who have insurance. So we sort of had a social policy, a criminal justice policy for 40 years that's taken the people who most need the help and then created a policy structure that prevents them from ever really getting it in a reasonable and a reasonable way.
This very patient people right there, I know.
Go ahead.
But I just also want to say that I would add the criminal justice system is traumatizing.
Sure.
I mean, if I went through the experience of all of those things and being thrown into jail, and I mean, all of that would be highly traumatizing. I mean, I think that counts as part of it.
Well, I know, but I'm doing a lot of work right now with the courts and trying to work with them as we start to treat substance use as a chronic disease, is to think about it as that, because I think you're perfectly right. We tried to build our way out of the drug problem by building jails and locking people up for substance use, and often it was minorities that wound up in jail rather than anyone else because of substance use. And we clearly could not build our way out of the problem. And then there's the trauma of being, institutionalized in a jail, which is not exactly, if you've ever been to a jail, I've been to several jail in LA, not a pretty sight. But we need to work with the criminal justice system too, to think about, as we start to think about this and framing this, and this is why I showed that slide again, that it's a chronic disease, is that, when I talk to some of the judges, I try and think, because the judges will say, okay, this person needs to be in treatment for a year. Well, we don't know if they need to be in treatment for a year. They need to be assessed. What's their medical necessity? What do they need? So they see it as a public safety issue. They just want them in a treatment program someplace so they know where they are and they can track them. And I try to say to the judges, you don't determine how much chemotherapy someone's going to get if they have cancer. And then the other part is, if someone commits a crime, there is a crime that has to be done. And if someone was using drugs, they still need to get treated for their drugs, or for their drug for their addiction as a chronic disease, rather than throwing them into jail. And they may need jail time for something. But again, I would go back to, I always wanted to bring this comparison, is that if someone commits a crime that is a diabetic, we don't not treat the diabetes.
Yeah. Go ahead.
My question goes to the policy. You're involved in policy, and I'd like to know what options, is there anything that the policymakers have to make other options for pain treatment more available? As the gentleman said, it's cheaper to throw somebody a bag of medication versus, okay, you've got a year of physical therapy or acupuncture or acupressure. I think one of the challenges is to make these other options more available on a chronic basis, as opposed to you have 3 months and then you're finished.
That is a great idea, and it's certainly that option is available. So the project that I'm on specifically looks at health insurance benefit mandates, and California has some of the highest level of benefit mandates. Some of the things have gotten a lot of press, like SB 999, which mandated that women get 12 months worth of birth control at once. And I analyzed that bill. It was wonderful. It was, one of those things where it was like effective and cost effective, and it helps people and lowers all sorts of bad outcomes. I think the kind of things you're talking about could also be those kind of wonderful bills, where if we mandate that insurance companies have to cover acupuncture, if we mandate that all insurance companies have to cover, and for me, I refused my doctor's Vicodin prescription and I did yoga, and now I have no more back pain. So I think yoga is a wonderful thing, but I did pay for all mine out of pocket, right? I had to go and pay for my own memberships and everything. I think those kind of other therapies certainly, if they were to be mandated legislatively, would then have to be included and covered, and I would love to analyze one of those. So I think from your perspective, you can look up who your local assembly and senate people are. If you go onto assembly.ca.gov or senate.ca.gov, put in your address, it'll tell you who they are. In mine in Orange County, even though I'm covered under Republican Ed Royce in Congress, and boy, are we doing a lot with that. But in my assembly and senate, I have Sharon Quirk-Silva and Josh Newman, both the Democrats who actually flipped the supermajority. And both of them are on their respective health committees. So, that would, if I were interested in this kind of thing, and now you're giving me something to do tomorrow, I could call them and say, I live in your district, and I think this would be a great avenue for you to pursue, that we should mandate that insurance companies cover these other options so that there's no question, all of the studies have shown once insurance access is there, other things become easier. And certainly there's problems of integration and systems and delivery and all that. But you've got to have the insurance coverage first just to even make it a possibility for most people.
And I would think that just one other point to add to this is what can help fuel this is the research. So the new CDC guidelines and research on pain and the effective treatments for chronic pain are pointing to other treatments and a really integrated approach being ideal for chronic pain conditions. And many, many Americans have chronic pain conditions. It's a very widely prevalent problem. But cognitive behavioral therapy, movement therapies, whether it be physical therapy, yoga, also acupuncture, in addition to non-opioid pain medications when necessary, that kind of integrated comprehensive, the idea of the comprehensive pain clinic pretty much died because it's not reimbursed, when this prescription opioid prescribing epidemic took off, because that was what was considered to be the optimal treatment for chronic pain. But we now know that that's not usually the optimal treatment for chronic pain. And I would think that the research and the new guidelines could help justify insurance coverage for what are recommended treatments for chronic pain.
Okay, so let's try and do 3 quick questions. So you quickly, and then you.
Okay, hi. So I appreciate all the conversation that has gone on around the issue of trauma and the issue of behavioral health and social determinants of health when it comes to the opioid epidemic. And I think that one of the things that we have to think about as well is on a prevention side. We have to be more proactive. We talk a lot about things like making sure that we're monitoring the prescriptions and how many prescriptions are going out there. But if we really look at the social determinants and look at how our society deals with trauma, that's going to be a huge impact and indicator as far as who was likely to become addicted to anything, not just opioids, but alcohol or other substances. So if we were able to screen for trauma, which we can do because we have the ACEs study, which we can do those screenings, and it's 10 questions, and it's very easy to do a study to see how much trauma has somebody endured. And we know that dependent on how much trauma they've endured, the chances of them having a chronic health issue, as well as having a behavioral health or addictive issue, increases. So we have these tools. It's just a matter of can we use them and can we put them into our systems effectively? Because if a doctor was to be able to look at somebody and say, hey, I want to prescribe this person some pain management, they've come in here and they say that they have chronic pain, but I also see that their ACE score is 7. Well, chances are that's really bad. And you would probably want to make sure that that person does not become addicted and that that they have an increased opportunity to become addicted. So I think we have to go beyond just, reducing our prescriptions, but also look at what causes the addiction process in the first place and really be able to screen for that effectively to give the prescribers that information that they really need to be able to prevent these kinds of issues.
I'm going to take that as a comment.
Is there a policy? I mean, if you know anything about policy that's going on with that?
Nothing came up when I was looking at this, so I don't think this is widespread. I would say that is an excellent idea.
Yeah, it was a great comment.
I think, the fact is UCLA School of Public Health is often on the cutting edge. I mean, that's why we're hired to do these analyses of bills that are being discussed in the legislature right now. They're relying on us to be able to say as experts, this is something you should be looking at and this is what you should be doing. So yes, excellent.
Thank you, and thank you for a wonderful discussion. I represent the biggest cause of this on the draft. I'm a primary care physician. We get blamed. And I happen to be chair of the Department of Family Medicine here at UCLA. I'm also chair of the Public Health Commission, so I try to take a broader view. Here's what I would say. Number one is the workers still here. Absolutely right. Only way we can get a social worker in our department is to write a grant and get it. And so the only way to approach primary care is you have to have substance abuse, mental health, and primary care in one roof. Everything is interconnected. People beginning to understand that. The second thing is even though we spend $3 trillion plus on healthcare in the country, we are woefully unprepared to deal with this epidemic as far as trained people. And what it's moving to now is medication-assisted treatment. And you should think of that as methadone 2.0. Now, methadone came out in 1971, and it was mainly used in the inner city, African Americans who were addicted to heroin. And you had to come in every day to a government-mandated clinic, drink the stuff, and you had to show up every day, and you would get a supply for the weekend. But you had to keep going to this clinic to get it. Now there's these new pills out, and I would call it methadone 2.0. There's one, naloxone, which is, or buprenorphine, and is Suboxone is a combination of a drug narcotic that will block your cravings, but also can't overdose, or it's just the antagonist all by itself. So those are the two debates. And it can be prescribed by a primary care physician now if you have a special license called an X license. And people say, well, you're just putting them on this for life. And you know what I say? I say, well, I have smokers that I can get them on nicotine gum. They want to chew it for life rather than smoking. That's better off. So it may be a substitution. Not everybody is going to be on this stuff for life. You bring in the other therapies. But it can work, and we are very excited. The third thing that has opened up is heretofore to be a trained addiction physician recognized you could only be a psychiatrist and had to go through that route. And just this past year, they have now recognized that you could come from 6 other disciplines and get trained in this. It's just opening up now. And we, family medicine, just got cleared for a fellowship, so we'll be joining you here because there's one fellow at UCLA now shared with the VA, and now we'll have something. But a massive university like this, and we're training one person, and we had to raise the money with a grant. So we're woefully unprepared. I think we're picking up, and Obama's bill and the responsibility to treat behavioral medicine the same as medical care, the big boost. Thank you very much.
Thank you.
So why don't we, those weren't quick, so I'm just going to observe that. But no worries, they were important comments. So can we, before I close, just give a big hand to our speakers? Okay, and then let me just read these final remarks, please. So thank you for joining us, and thank you for the invitation to come to the West Side. That's something I do a lot. It's a little cooler here, so let me do it more. I also want to acknowledge the help of Mike Alpern and Lori Pelliccioni. We said it 2 times. They're alums of the Fielding School and members of the Health Forum Advisory Committee for their leadership in developing this evening program. I also want to highlight some excellent future events, which I can say I just read this. The next Health Forum, which is amazing, perhaps better than this, maybe. And that includes, in collaboration with the DeMont Foundation, UCLA Center for Health Advancement, will be presenting Public Health and Politics, Examining the Surgeon General. Very timely since the current Surgeon General was just fired. The evening will include a short documentary of the same title in which interviews with public health leaders are combined with archival recordings to look at the tensions between politics and public health through the eyes of the U.S. Surgeon General. The film will feature the 16th Surgeon General of the United States, Dr. David Satcher, the 17th Surgeon General of the United States, Dr. Richard Kamoni, and the longtime Executive Director of the American Public Health Association, Dr. George Benjamin. A panel discussion will follow with Dr. Phil Dean and Ed Hunter, President of the DeMont Foundation. So thank you for coming, and I hope you'll be able to attend the event next month.